Welcome, everyone, and thank you for joining us. We have a great show ahead of us, as always. This is your show, and you have so much planned for us. We're looking forward to it all. Thanks so much. It's all yours.
Thank you very much, Jamie. Yes, we've got a very important program here today. We're going to cover a lot of things that have been in the news media here in the last 10 days. We've got an old friend, Donna Wilkes, that we're going to chat with in a few minutes. And I happen to know that Dr. Ibsen and Dr. Guess have some things that are quite relevant to say today. Uh, One of the things that's on my mind today, and the educational message that I want to give, and one that I've promised to give, and that is to continue to try and educate people on what this Epstein-Barr virus issue really is all about. Uh, and I'll start with this by saying is that unfortunately that virus has been around a long time, known as the kissing disease. People just aren't taking it real serious in some ways. And in other ways, the new research is why it's come to the forefront. And it's a little hard to grasp. It's been hard for me to grasp exactly how these parasitic viruses cause autoimmunity. And it's come to pass that it causes more than one type of immunity. At any rate, let's start with we're going to call some very basic stuff here today about Epstein-Barr virus for the next 5 or 10 minutes. Now, first thing you want to know about the Epstein-Barr virus is number one, it's part of the herpes class. There's about 9 herpes viruses. Cytomegalovirus virus is one of them, incidentally. But it's the Epstein-Barr virus is unique among all viruses for one reason. It's the only virus that can cause cancer. Okay? COVID doesn't cause cancer. HIV doesn't cause cancer. West Nile virus doesn't cause cancer. But Epstein-Barr virus can. Now, that should tell you something right out front. It should tell you be afraid of that virus. Okay? And you should be. Now that we're learning about it, it's a little scary, to be honest about it. Now, the second thing about this virus that you need to know, its official label in scientific circles is it is opportunistic. Now, what does that mean? It means that this virus is one of the parasites that if you give it an opportunity, it's no longer a parasite. It wants to take you over. Okay? That, in other words, it's waiting for you to have something bad happen to your body or to your immune system. Then it goes into action. It's just waiting, apparently in all of us, to take us over, to cause us disease. Okay? So, cancer, opportunistic. The third thing you have to know is that the virus enters the body in most people before they're age 2. And sometimes you catch infectious mononucleosis, which is just Epstein-Barr virus entering the body and causing you a throat problem. But it can be a pretty serious illness too. But then the virus settles into your throat membranes, but mainly into your lymphocytes. Now, one of the problems we have is that people maybe have heard the term lymphocytes, and now today, a lot of medical journalists like to write about killer cells, T cells, and all of this. Well, you really don't need to know any of that. What you need to know is that lymphocytes are floating around your body and that the viruses may be hibernating in them, waiting to get active. Okay? Waiting to get active. Now, why does the Epstein-Barr virus takes the opportunity to activate or reactivate? It does so only under one condition, and that is something has happened to you that your immune system is weakened. It's not up to par. Doctors or scientists like to call it immunocompromised, meaning simply that your immune system isn't up to snuff. It's weakened for some reason. Now, this is terribly important because you have to know exactly what we mean by this. Now, let's talk about things that we now know by research and by studies that activate or reactivate the Epstein-Barr virus and cause your immunity to drop. Now, the most common one is trauma, okay? An auto accident. You fell off a roof. But the one that people seem to be having trouble with is that medical procedures are trauma. Now, we're having, my mailbox it's not full, but I'm getting comments. They say, well, my arachnoiditis or my RSD or my fibromyalgia or my spinal fluid leak, these things couldn't have been related to the virus. Well, I've got news for you. If you catch an infection or you have some trauma to your spine, to your knee, to your ankle, or to your head, your immune system is going to go into overdrive to help it, but it also wears it out, and that virus will activate. Okay? That virus is going to activate. And so people need to understand that epidural injection, that knee surgery, that spine surgery, that gallbladder surgery, you're probably going to activate the virus because your immune system is automatically going to be compromised. Now, this is a hard lesson for us humans. Okay? This is not pleasant. And but I don't know how you get around it other than to know that when you have trauma, whether you fell off a roof, whether you had an auto accident, whether you got hit playing football, you may have lowered your immune system just enough to activate the virus. And looking at the studies, it looks like some people have reactivated their virus multiple times in a lifetime. Some of the antibody levels are so high in patients that the labs can't measure them. That's how high they are. So we know that these people have a compromised immune system and they've reactivated the virus over years. Okay? So that's what's happened. Now, why else will that virus reactivate? Infections. Okay? We get a terrible throat infection. We get a skin infection. We get a cut that gets infected. We get any kind of an infection. That's going to lower your immune system, and you can get activated there also. Strokes will do this, for example. Heart attacks. Any medical condition will activate the virus. The other thing that may activate it, there are some studies, they're not in humans, but there's indirect studies saying that severe psychological trauma can reactivate the virus. And I think every one of us on this program have had a time in their life where we were undergoing some stress that depressed us, gave us fatigue, paralyzed us, depressed us. Apparently, that also means your immune system may have dropped a little bit and gave that virus the opportunity to reactivate. Okay? Now, I guess what people are not happy about is that they somehow want doctors to explain why if you hurt your wrist, how do we reactivate a virus that's floating around in the lymphocytes? No, there's no wires. There's no string. There's no tube, there's no computer, there's no electronic signal, or not one that we understand, but there are biologic signals in the body that, believe it or not, you stub your nose, that lymphocytes are floating right through your blood, and it'll get triggered and get notified that you just fell on the cement and hurt your nose. Okay? And so those lymphocytes are all ready to be activated at the drop of a hat. Okay? I mean, they literally will activate within seconds. And so can the Epstein-Barr virus. Remember, it's looking for this opportunity to reactivate. Now, here's the hard part that people are having trouble with. When it reactivates, the virus does two things. Okay? Two things. They're both bad. There's no getting around it. Okay. Number one, it infiltrates tissues. It invades tissues. I'm going to come back to this in a second, particularly for those of you out there who's got EDS or diabetes or something. You're going to come back to this now. And the second thing it does is form some autoantibodies. Okay? And we're not 100% certain how it forms the autoantibodies, but it does. And this has been documented, believe it or not, since 1974. This is not new information. What is new information is that some of the new tests that you can get just by going down to your local laboratory, and they'll send a specimen off to Quest or a LabCorp or some other regional test laboratory, and they're all good. These new tests are pretty standard. They're excellent. They're high powered, and you can take a look at there's 5 tests that are available, and you can look at 3 of those or 2 of those and really see a whole panoramic picture of what's happened to this individual. Okay. And so anyway, these are the 2 things. But here is the pitch. Here's my underline. Here's my take-home message today. When that virus activates, it will leave the lymphocyte and enter your tissues. But here's the message. What tissues? Okay, listen up, folks. It's going to enter any tissue that is damaged from trauma. It's going to love to enter any tissue that's inflamed. Okay, like maybe the inflammation after an epidural. It's going to enter tissue that is weakened by either nutrition, but here's the big one. If you have a connective tissue disease and you've got some collagen deficiencies, the virus loves to invade the tissues. Okay, this is why people with EDS, Marfan's, or any of the other connective tissue diseases, dwarfism, for example, osteogenesis imperfecti, you're going to be much more prone to have Epstein-Barr cause you a painful condition or a cancer than other people because you've got a genetic inherited collagen deficiency problem, and that tissue isn't just quite right. Now, what about these tissues? The tissues that it loves to invade are those that are not hard tissues. It wants the softies. I guess they're more juicy morsels, if you will, like small nerve fibers, intervertebral discs, like in your neck or your lumbar spine, or your small nerves, maybe your carpal tunnel, maybe the meninges around the brain giving you all the migraine headaches, okay, or maybe the fascia around your muscles giving you fibromyalgia. So the virus likes to go to weak tissues or inflamed tissues. And here's the one that people seem to be having a hard time about. And I realize some of this is due to litigation and lawsuits on both sides. Somebody, for example, has a spinal problem, spinal leaks, arachnoiditis, multiple sclerosis, slip discs, herniated disc, cauda equina inflammation. Though you may have, for example, maybe the surgeon had an accident and cut your dura. Maybe you had an epidural that went wrong. Maybe you had a spinal tap that got things contaminated and gave you an infection. And so people say, well, that's what caused my arachnoiditis. That's what caused my multiple sclerosis. Yeah, it did. Okay. But it caused acute inflammation. That inflammation attracted the virus later. So we now are starting to understand, and we don't know all the details yet, but when you go from having an infection or an inflammation, for example, in your spinal cord or in your small nerve fibers or your muscles, you may start off with something causing inflammation. And all you're doing is inviting the virus in. And the virus then makes the shift from acute inflammation, acute damage, to chronic autoimmunity. Now, let me tell you the other thing that is new in research. It's a little hard to grasp this one. In fact, we're going to have to grasp it, but it now turns out that besides autoantibodies in the blood, the virus is now known to do what it caused. Some doctors like to call it cross-reactivity or autoreactivity. And in the cell itself, like in the cauda equina or in the discs, it causes some of those cells that turn on themselves. And that's called autoreaction, is probably a common term, or cross-reactivity, but it's a different type of autoimmunity. Now, the reason why I'm so interested in this has to do with those of you out there who suffer from RSD or CRPS. We have people watching this show who I know they started off with maybe a sprained ankle, maybe a sprained wrist, maybe they hit their face. They start off with a little pain, a little something or another, then it starts to spread. For example, I heard from somebody this week, they started off with a sprained ankle. Then it got painful, and then it got real painful after 2 or 3 months, and then it started to spread up the leg. It went clear up the leg, into the hip, into the abdomen, then into the chest, then into the breast, then into the jaw. Teeth are falling out. In other words, it started on one side and just crept upward. We now think that's due to this new discovery of what we call autoreactivity or cross-reactivity autoimmunity. And we think that's what's causing that. So anyway, we will be progressing with this understanding. And now I'm going to leave you with one bit of good news. Preventing reactivation is the cornerstone of controlling the Epstein-Barr virus. And that's pretty easy to do. Okay. Now, you've also got to take some other steps, and people are doing this all over. Doctors are really starting to come on board with this. I'm pleased to see it, but we've got a lot of education to do and a lot of new concepts that are hard to understand, and they're a little frightening. With this, I want to turn next to, I guess, what is kind of a new thing here on TikTok, on our podcast. And that we've sort of developed a media watch. Now, I know Donna, I want to ask Donna about this later, as well as Dr. Ibsen and Dr. Guess. And that is, we're starting to understand that in the last 20 years, and I invite people to make comments on how it happened, but there was some kind of a propaganda effort that turned the public against pain patients, pain doctors, and opioids. And as you know, the federal government, state government, medical boards, insurance companies, hospitals, health plans, doctors' clinics, they don't want to have anything to do with opioids or pain patients. Okay, and we're fighting this. But one of our root causes has been the media has just beat us up. Okay, now I want to sort of call this our media and mail program. And I want anybody out there who gets some ad in the mail or anything in the mail or sees anything in a newspaper, magazine, bring it forward, because we need to, and I think we're having some impact. I'll ask Dr. Ibsen and Dr. Guess and maybe Donna about this later. I think that some of our catching media is starting to turn around. Now, I've got a few things I want to call to your attention. First off, a lot of you probably don't know this, but here's the doctors, the Pain Specialist magazine. This latest edition, here in February, is the only edition I've seen in years in which they weren't bad-mouthing opioids. This one doesn't have any negative things about it. So to me, that tells me maybe they're getting the message a little bit. I have here something called Bottom Line Personal. Now, you may or may not be familiar with this magazine, but it's taken by, I think, a few million people. Very popular. I take it personally. It's got a lot of great things in it. It's a great magazine. But then there's an article that shows up in here this week. It's called Natural Pain Relief, Non-Drug Ways to Manage Pain. Okay. Now, I'm going to read you what it says. It says right here, over-the-counter OTC non-steroidal anti-inflammatory drugs, NSAIDs such as ibuprofen, Advil, Motrin, And more potent prescription opioids, Vicodin and OxyContin, certainly have their place when it comes to treating specific types of pain. But they also don't always work. New research from VA Connecticut Healthcare System and Yale School of Medicine indicates that opioids, often used to treat chronic pain in older adults, may increase risk for cardiovascular disease. Well, opioids also are linked with sedation and dizziness, as well as increased risk for falls and fractures, according to research from Aarhus University Hospital in Denmark, and they are also known to be addictive. At least they said they were used for some specific types of pain. Now that sounds like they've gone ahead and badmouthed all the opioids and indirectly all the doctors who prescribe them. But at least they said that it was good for some specific types of pain. Considering where we've been, that's a step up. Okay. Now, but what's this article really all about? It's a paid advertisement. It's advertising the new capsaicin form of drug, and which is good. It's a good drug and useful, but they didn't have to badmouth opioids so bad. And one last thing, we had, and Dr. Ibsen has championed this. If you got high blood pressure, the first thing you want to do is see if you have pain. You can't keep your cardiovascular system together if you don't keep the blood pressure down so the heart can relax. Well, they've come up with a couple of studies saying, oh, if you take opioids, you're going to get heart attacks and strokes and everything. I've read them. I'm not going to go over them in great deal tonight because of time, but they're almost fraudulent, in my opinion. Yeah. Here's another one that just came out this week. That's what I say, when you start looking for all these things, you start finding them. Now, here's one here. This is in Epic Times. Article, chemotherapy causes chronic nerve pain in nearly half of cancer patients. Okay. Well, I didn't think chemotherapy did that so much. But what they do say in here, which is very interesting, they say that the nerve damage due to chemotherapy is so bad that sometimes you have to take opioids, and they sanctioned it. Epic Times, because they haven't exactly been our friends. It says here, while efforts to reduce opioid use exist due to risk of addiction or misuses for cancer patients, these medications may be the only way for patients to continue to tolerate their cancer-directed treatments and preserve quality of life. Epic Times printed that this week. Step up for us. Okay. Well, now, USA Today has been really active out there today. Now, last week, front cover, there you go. The state of pain in America. USA Today, whole front page. Okay. And it looks like they're really after us, but you do have to realize it's a paid advertisement. Okay. By Vertex advertising their new anti-inflammatory agent. But millions of people saw this now. And so you can maybe judge for yourself, what do you make of it? What's the impact going to be on the public when they put out the state of pain? Here's the big point. Prescriber concerns. For those of you out there who can't get help from a doctor or wonder why your doctor's not treating you right, or maybe just plain mean, listen to these data. Again, millions of people saw that this week. 88% of healthcare providers surveyed reported that their patients prefer to manage pain without a prescribed opioid. Okay? So 88% of medical prescribers, according to this, don't want to prescribe opioids, is what it says. Because indirectly, opioids are bad, of course. Here we go. 78% of healthcare providers reported concern about the risk of opioid addiction among their patients with moderate to severe acute pain. That means that almost all the doctors out there think all of you who take opioids for pain are at big risk to become addicts. Okay, so that's, again, front page. And over here, they're talking mainly about acute pain. So at any rate, and they're saying here, 77% of patients surveyed said they are interested in trying a different pain medication if they experience acute pain again. 52% of patients surveyed said they are seeking a new pain medication with fewer side effects than their last medication. Now, did this help us? It's subtle. This is the propaganda. This is how propaganda works. It's subtle, but it leaves a subliminal message that is stuck with people. So this alone is on all the newsstands, airport. Millions of people saw this week. Now, to give them credit, USA Today, 2 or 3 days later, published this article. It's an editorial called CDC Causes Patients to Endure Needless Pain and Suffering. Kennedy Can Help Opinion. They published this wonderful article, opinion page, by Dr. Jeffrey Singer and Josh Bloom. Now, those are friends. Those are doctors who have been advocating for pain patients and pain doctors and calling attention, along with some of our other people, like Kristen Ogden and Red Lawhern and some people, like you're going to hear from Dr. Ibsen in a second. This is a wonderful editorial. Okay, couldn't be better. Couldn't be better. And it goes on to talk about how CDC has, and I'm not quite sure whether they put incompetence or maliciousness at the top of the reason for CDC running their guidelines of 2016. But they did put something in here that I don't think the public still and patients have still not grasped. And I'm going to see if I can find this for you. Then I want to call on Dr. Ibsen and Dr. Guest to respond to this. First off, prescribing opioids have peaked in 2012 and is now at 1993 levels, a reduction of about 50%. So opioid prescribing in the country has been going down for a lot of reasons. Okay. So it's way down. But what I wanted to particularly call to people's attention, I don't see it here right offhand, but fundamentally what they said was the CDC guidelines were just guidelines. They weren't a law. They weren't a regulation. But when it comes from the top health organization in the country, it's a de facto law. And I can tell you that it really affected insurance companies and malpractice. And it said in here that here it is right here. By 2022, 40 states had enshrined the CDC's 2016 guidelines into law. 40 of our 50 states. Now, that's why when you go above 90 milligrams of morphine equivalents in 40 of the states, you're breaking the law. It's a crime. And that's why they, in effect, have criminalized prescribing and why a lot of you out there can't get opioids. It's against the law still in 40 states to go above the CDC guidelines. Mark, are you there?
Yes, sir.
Yeah, okay. First off, why don't you give us your rendition of what the Dr. Singer's article and Dr. Bloom's articles? Oh, I'm sure you agree with it, but can you make your comments on what you think about it? Where does it leave us, good, bad, or indifferent?
Well, the fact that they got a national publication like that to publish this article is really great. Hopefully there'll be hopefully they're right about Robert Kennedy Jr. Maybe helping. There's a lot of hope in that, and kind of disrupting the status quo, I suppose. With the status quo being opiates bad and patients are addicts, none of which is true.
Yeah, we lost you, Dr. Guest.
I'm here, Dr. Tennant.
Great,
Good
great,
afternoon.
good. Okay, there you are. Let's give us your thoughts on this article, what it means, any special points you want to emphasize.
His opening paragraph. I, as a retail pharmacist, a community retail pharmacist, actually, I'm going to do him better. He said not a month goes by. I can't go more than 2 days without at least 3 people calling and asking if they can start using my pharmacy to receive their opioids. And I have to tell them all no, because due to the CDC guidelines, DEA restrictions, all that, I can only buy so many doses a month. And I am maxed out with my current patient load. So that first paragraph really, really rang through. And then they use that term, pain refugees, and that is absolutely real. That's been referenced before at national conferences and the like. And they are the results of this is some patients are desperate enough to turn to the streets, and then they get tied up in that garbage that's coming over the border that's full of, that's fentanyl or maybe been washed with benzene or who knows what. And it's we talk about this lack of care and this roadblock to care causing harm. The overdoses that are happening to our legitimate pain patients, and I hate that term, I choke on the fact that I even said it, that our pain patients are having to go to the street to get any kind of relief at all. It's just killing them. I like the fact that they're trying to get something done. I know, our RFK Jr. is a little bit of a rabble rouser. He might be enough of a rabble rouser to do that. I can only hope so. I don't know if he's got the inclination though. How do we get that inclination to him?
That's a good point. That's a good point. While we have you here, Scott, you and I, this week, you had another issue that I would like for you to briefly address, if you would. As I understand it, you and a number of pharmacy-related institutions and concerns in the state of California are demanding that the pharmacy board be disbanded or the current members be disbanded. This is one of a type. I've never heard of anything like what you guys have done or what you participated in. Would you tell us a little bit about this unhappiness with the pharmacy board of the state of California?
And this is not just the pharmacy board, but every regulatory board, contractors, plumbers, hairdressers, physicians, all those boards every 5 years go through a process, or is it 8 years? Go through a process that's called a sunset review. And they have to come back to the legislators, and those are usually the legislators that are on the Business and Professions Committee, and have to sit and kind of what is happening in the federal government right now, and validate that they are doing the job that they have been tasked to do. Our sunset review for the Board of Pharmacy is coming up this year. Actually, we're in the middle of it right now. And there's a group of compounding pharmacists that are expressing concerns over overcomplicating the regulations around compounding, exceeding the requirements of the USP, United States Pharmacopoeia, which is a national organization that's been around since the 1860s and considered the gold standard in compounding. The medical board was there. They were claiming overreach by the pharmacy board, trying to regulate physicians and what they do and what they might mix up or compound in their offices. Veterinarians were there, and the naturopaths were also there because of this overreach that the pharmacy board is trying to regulate other professions that they don't license. But it's kind of it's a symptom of an infection where they have forgotten that they're supposed to serve the patients, and to serve the patients, they also have to serve the people they license. And they've kind of gotten this little fiefdom going, and they want the power, and they're forgetting the laws and the regulations that they're bound by.
Yeah. I think one of the things that the public is not very well aware of, but boards involving pharmacy, medicine, nursing they are we looking at just a group of political appointees who just don't care anymore, or they're not qualified? I mean, there isn't a day goes by we don't have a problem hearing about boards, and the whole CDC guidelines were written by people you never heard of them. They weren't qualified. Obviously, they never published a paper. These boards are now filled with people. You wonder where they came from.
They are all political appointees. You have to send in you usually have to make an application, but sometimes if you're just a good donor, or you have a special interest group that wants a particular person on a board, they will work with the governor to get that person there. I've had my application to be on the Board of Pharmacy in for over a year now and haven't heard a thing back from anybody. Yeah, they're just political appointees. And in this particular sunset review that we're after, we're focusing on the compounding regulations, and there's not a single person that has compounding expertise on the state board right now. And they're writing all these regulations that are more restrictive than the USP guidelines. And the USP people are experts.
Mm-hmm. Do you have any quick idea on how, I mean, from what I can understand, the medical boards and the pharmacy boards, including the osteopathic boards and nursing boards, they've not been on our side. That's been it's like they're all filled with anti-pain, anti-opioid people. So how did that happen?
The CDC guidelines. The mandatory, I don't know if you remember the death certificate program that they had in California a couple of years ago, where, if any patient died and there was an opiate in their system, they investigated all the doctors that patient saw, dentists, nurse practitioners, the pharmacist, and the physicians. Whether you prescribed that medication or not, you were under investigation by the medical board, because there was an opioid in that patient's system.
And doctors haven't come back either, have they?
There are a number of doctors that haven't come back. Some of them voluntarily. They said, I'm getting out of this state and going to another one. And others just said, nope, I'm just going to retire. I'm not going to spend my entire retirement fund to defend my license. I'll just retire now.
Yeah. Well, there's a lot of us in that category.
Yeah, I believe I'm looking at one of those right now.
Yeah, sure. There's we might, if it would be, you probably would not want to hear why those of us who have retired from that business, why we really did so, but it's not nice stuff.
I have a rough idea.
Yeah, I want to move on now to our special guest. She's really not a guest. Donna, you're here. Calling you a guest is really not the right word. You're sort of one of us. You're always saddled up and got your guns ready. So so you're always here. Donna, for those of you who don't know a lot about your situation, could you give us some of your background, both professional and clinical?
Okay. Well, when I started out in college, I was pre-med and I graduated with honors, but in my second year, I injured my back on the stairs. I didn't know I had scoliosis, and I ended up with arachnoiditis diagnosed when I was 19 years old. Okay. So eventually I realized I didn't have the health to go into medicine, but I went to graduate school and got my master's in the history of science. I really enjoyed studying the history of science and medicine, but it was difficult. That's putting it mildly, just getting across campus because things weren't accessible back in the 70s. And then doctors, they didn't really understand adhesive arachnoiditis. My diagnosis kind of got overlooked and sometimes neglected. And they did a lot of things in efforts to help me with pain that actually made it worse. In fact, I had 3 myelograms with Pantopake, and actually 4. the first one actually diagnosed the arachnoiditis, so it couldn't have been the cause, and they know it wasn't, but still it worsened that time. But anyway, I always had a difficult time. I know a lot of this backlash started in 2016, but from the start, I've had difficulty getting adequate pain treatment. This was back in the 70s. And in fact, I know someone mentioned about getting so many NSAIDs that it damaged their stomach. That's all they would give me for years and years, and until it got so bad that now I can't even put topical Voltaren on my wrist without feeling a stabbing pain in my stomach immediately afterwards. And now I have what you call it, peptic ulcer disease, and I had esophagitis and hospitalized because it was erosive and causing spasms, which felt like I was having another heart attack. Okay. So, but that's all they wanted to give me. And in fact, I remember when they did a procedure on my neck, they gave me a 15 milligram codeine tablet for pain. Okay. And I heard the nurse say, "Is that all they're giving her?" Anyway, I mean, I kept saying I was in pain, and it didn't, and it was like, because I wasn't terminally ill, it seemed like that was the key thing. I didn't have cancer. And that's why even in the 70s and 80s, I had real difficulty getting adequate treatment for pain. So unfortunately, this feeling among doctors isn't new. In fact, when I had my first colonoscopy, and those they just called it a lower GI, okay, I didn't know that I was supposed to have proper anesthesia, okay, or light sedation, whatever. When a doctor mentioned that he was going to give me these two things, I said, well, they're not effective on me. They don't relieve pain and they don't sedate. He used them anyway. And I screamed through the entire colonoscopy. I was wide awake. It was torture. And this unfortunately has happened repeatedly. This was back, oh, wow, in the early 80s, this happened. And so I have never seen where doctors that I had, and even when pain medicine became established and I started going to pain doctors like in the late 80s, and in fact, one of my pain doctors prescribed, this is actually later, prescribed so much OxyContin that it actually made me dizzy, and I cut it back myself. But still, and then when I go to the hospital, they wanted to cut that back when I was taking. I mean, that wasn't the first thing. They went through the steps: Tylenol 3, Tylenol 2, Tylenol 3, Percocet, actually Ultram first before, finally by the late 80s, early 90s. But it never really, and I had all those things, but a lot of the anti-inflammation meds, like Tramadol by that time, hurt my stomach so much I couldn't even benefit from it when they finally did start, trying to do something. So, I honestly have not seen where doctors have been that responsive at all to pain. And I don't know whether it's because I'm a woman or a woman of color. I just don't know what it is. But I've not gotten, until very recently, and still it's a battle, even though I'm in a nursing home. I mean, I finally got some of the nurse practitioners to understand the level of pain that just sitting is the most painful thing I do. And, so that's basically, I hope that answered your question, Dr. Tennant.
Well, you bring up a point here that I want to dwell on for a minute. Now, you've had your arachnoiditis, your problem, which, am I correct? It sounds like about 40 years.
I'm 71, so it's been over 50 years.
Been over 50, no. Yeah. And throughout this 50-year period, you've had resistance. That's one of the reasons why I wanted to talk to you tonight. This resistance isn't new.
No.
And it's as irrational today as it was back then. So, I continue to be mystified where this came from. I've just, you know, you never even hear anybody mention the Hippocratic Oath anymore, because doctors in those years, they believed in this. You go back in history, the Sumerians, the Egyptians, they all treated their patients with opioids clear back in those centuries. And all of a sudden we end up, and during the 1800s, you could buy a patent opium, and after the Civil War, we treated our soldiers very good with opioids. The famous Doc Holliday survived his tuberculosis way beyond his time with opioids. And then all of a sudden, we're here now, and you have to say these people 100 years ago got better help than we do now. I mean, the Brompton cocktail was 1895, where they gave, and now, my God, the whole idea of giving a stimulant with an opioid is, or a benzodiazepine, oh my God, we can't do this. I'm still mystified where it came from. I mean, and you're a living proof that you've faced this for, I don't know why you're still alive, to be honest about it, Donna, but
Good Lord. The good Lord.
maybe you can
telling
tell
you.
us how you managed to do this. Anyway, how have you survived all this time with all of this?
Honestly, I have to say, it humanly would have been impossible. I mean, I thank God that my family, for the while they were living, and even though it's a small family, has been supportive, very supportive, and they've always prayed for me, prayed with me. And I know that the good Lord, honestly, is the only way I'm still here, because I know I would have given up and felt tempted to give up many times, especially when I couldn't seem to get anyone to pay. I mean, I was in Johns Hopkins Pain Clinic in 1975 and 1976 when, they said it really was not for people who had a diagnosed condition like arachnoiditis that demonstrably caused pain. But no one told me that at the time. They just put me there, and they would not even give you a Tylenol. I mean, they gave us psychotropic, mind-bending drugs. I was trying to go through college taking antipsychotics, antidepressants, anti-seizure. Now, again, I think we were guinea pigs. They did learn from some of that, and but at what cost? Again, having to taper off those things. And I was forced tapered too by an osteopathic physician, because he didn't know then. And again, I was still going to doctor trying to find out, well, why are they treating me this way? And then they diagnosed CRPS, and I had really manifest symptoms of that. And so then that overshadowed the arachnoiditis. So the treatments they would give me for that, like epidural injections and things, just made the arachnoiditis continue to get worse. But honestly, and again, I mentioned last time, the emblem behind me is a symbol of the Franciscan order. I was attracted to St. Francis of Assisi, medieval saint, because of his joy, his love, his humility, love of poverty. And it just impressed me as a child. I live in Washington, D.C., so it's the home of the Franciscan monastery, or as they call it, the commissariat of the Holy Land. They have a huge replica on acres of land of the Holy Land shrines that exist, unfortunately, may not exist much longer in Jerusalem area. Anyway, and I started studying with them at the earliest age that I could at the time of the old Constitution. I mean, eventually the Vatican updated it where you had to be 18, but I was 14, and my parents had to drive me for like 3 years to get to the meeting. So again, without parental support, and again, I wouldn't even have been able to be professed if this had happened before my 18th birthday. Just 6 months later was when I fractured my spine, and it damaged my dura and arachnoid, apparently, because it was diagnosed less than a year later. And but I just thank God for the graces of the Franciscan vocation for me. Really has still made such a difference. A discipline of prayer, morning and evening prayers required, ongoing formation. We meet, unfortunately, my original fraternity deactivated last fall because we're not that many in number anymore, but we merged with a nearby fraternity. I think it's an old term for fraternity. It means men and women, but in the old days, it was referring to the friars who, originally were part of the order. But anyhow, this is for laity, and but that has really definitely made such a difference. Okay.
Mm-hmm. Back in the 80s and 90s, before we had the fifth vital sign, did you ever hear in any of the medical facilities you attended, did anybody ever talk to you about the World Health Organization three-step ladder for opioid treatment?
No.
Did anybody in those periods ever talk to you about the cocktail?
I read about it through disability magazines when I read about the Brompton cocktail. And I was interested in that. And, why couldn't I have gotten palliative care, for instance, especially, 20 years down the line, 25, 30. But they said, well, you're not in hospice. I mean, they link hospice and palliative care. That's another link I think should not be. You should be able to get palliative care without being 6 months or whatever the hypothetical insurance payment is for people who are terminally ill, without having to have that be certified. Okay. And that's one of my other things. I don't think the two should be linked.
Mm-hmm. Do you know what law or regulation at the federal government level, let's take DEA, not CDC, but DEA. What does their law or regulation say that a physician can do relative to prescribing opioids? Do you know?
Well, I can't quote law specifically because I'm definitely not a lawyer, but I think they've harmed physicians. There's no doubt they've harmed physicians. They're a drug enforcement. They're a law enforcement agency. They have no business. My feeling is they have no business in medicine. I mean, they should never have gotten involved in this. But again, after money's dried up and the war on drugs, against the cartels was so costly, and people were talking about austerity and government cuts. Well, who's an easier target? Doctors don't carry automatic weapons, and pharmacists don't either. So that are on them, and that's what they've been doing ever since. Because sadly, they become a target because the DEA doesn't know who else. They don't need to. Honestly, I don't even think we need a DEA in the form it is now. I think it is harmful in the form it is now. But,
yeah. That's pretty clear.
Can't do anything about it,
Now,
yeah.
They discipline, they arrest doctors, they condemn use. So who do they say can get opioids in this country?
People who are dying, apparently. And even then, I've seen articles where they're trying to keep dying people. It's almost like we're on a roller coaster that's heading off a cliff. And how do you stop it? It's like people have taken an idea or a bad idea and just continue to take it to the extremes. Yeah, I've seen articles asking, is there other things other than opiates they can give to cancer patients who are dying? I mean, for heaven's sakes, if they can't, what are we turning into? What kind of monsters is this country leadership? What are we,
Can I say something?
Yeah.
Could I say here?
Yeah, sure.
What for sure. I tell you what the DEA says, and this comes out of an article we just wrote about Joe Ranasuzi. We call him either he's a hero, villain, or a criminal at large. And this comes from 3 letters that were sent to Red Law Hearn, Nicholson, a guy named Nicholson out of the Pharmacy Association, and Dr. Walter Wren. And we summarized this in this last article, and you were within the norms. And the DEA has consistently and it says here, the DEA has consistently underscored its authority. It derives solely from the Controlled Substance Act. And this is what they said. It says the DEA supports the individual practitioner's authority to prescribe substances for legitimate medical purposes within accepted professional judgment.
All right, now let's stop right there.
Yeah.
That's the only thing at the federal level that gives physicians the right to prescribe. Now let's repeat what you just said.
Okay.
I don't think many.
It says, and
Norm,
this is from the DEA itself. This is from Mr. Pravazny. He says the DEA supports the individual practitioner's authority to prescribe controlled substances for legitimate medical purposes within accepted professional value. Now, here's what it does. The DEA further acknowledges concerns about the impact of guidelines, specifically CDC, and highlights its support for legitimate pain treatment. Ultimately, the DEA, this is what it says, clear interpretation to respect the professional judgment of the medical practitioner and limits the DEA's authority in its realm. This is, this comes right, if you look at these letters, in fact, they go on and state that they do not dictate the practice of medicine to physicians, and they do not dictate and there is no such thing within the federal law as what we call a legitimate medical standards. Take a look at it, because this is important in the filing of our letter or our brief to the United States Supreme Court. They are using what we call subjective criteria, which they're not supposed to do, to make a determination. These subjective criteria, which they say they can't do, to then go around and arrest doctors. Subjective criteria includes morphine milligram equivalent. Subjective criteria calls when they restrict, for example, medications like Dr. Guest talks about, restrict them in certain pharmacies, set limits and those sort of things. Based on what? This is not based on science. And Dr. Tennant, you've been identified what the problem is, and if you look, and this we did an if you look at the brief that we filed before the Supreme Court, and I did an evaluation on it, it talks about this and why the court, we're looking at bringing this case back, because these subjective values are some authority that they've taken. They don't have. They're a law, as young lady said, they're a law enforcement. They have no business in it, in the field of medicine, and the DEA says that. But yet they get.
Well, we're about to run out of time, Norm. But
sorry,
you're right. I mean, this is the word legitimate is what it's all based on, and they decided what's legitimate and what's not. Now, at one time, I think the DEA literally did do it right.
Well, they're saying here, the DEA does, this is the DEA talking now. It's not Norman and Dr. Tennant. The DEA does not act as a federal equivalent of a state medical board overseeing the general practice of medicine. The DEA lacks the authority to issue guidelines that constitute advice relating to the general practice of medicine. That's the DEA talking. Look at these letters. The DEA has, and this is what, and I'll let this one sentence go, Dr. Tennant, you're right on this thing. It says the DEA has promulgated new regulations regarding the treatment of pain. Federal law and the DEA do not impose specific quantitative minimums or maximums limited on the amount of medication that may be prescribed to a single prescription. That is right out of the DEA mouth, and they repeat it 3 times.
Yep. You're absolutely right. All right, we're running out of time. Donna, thank you again for being here.
Thank you.
Another good program. We will carry on. Let me just close out by saying, again, let's keep our media and mail situation going, because Norm, you articulated it very well. Donna, you have too. The federal government has been able to get away with this because the public's behind them.
And there's no recourse.
And there's no recourse. Yeah. And so we have this problem of we can't let news articles, we can't let media, we can't let anything just slip by thinking it's going to work out everywhere. I think we've now learned one thing about all this. The people who are on the other side aren't going to change. We are not going to win the argument. We just almost have to figure out how to build a new system. Okay. And, you know, I'm going to give you a little secret. I used to work for the DEA. Years ago, I was their consultant. We took that word legitimate serious, and we actually had in-house ways to determine legitimate pain, doctors. Legitimate pain. That's not hard, folks. And at one time, I got to tell you, this might shock you. I started my pain clinic because the regional DEA guy said we got people that need help, and the local LA County Sheriff and our governor and everybody, Republican, Democrat, bureaucrat, clinician, said we want people treated. Okay? So don't tell me that they can't do it right. They have in the past, but something went wrong. Okay, and Norm, you well said it. Donna, you've experienced it. Dr. Ibsen and Dr. Guest live it every day. So anyway, we're making headway, folks. Okay, let's keep going, and we'll be back next week again. We'll have another good program. All of you, keep charging. Good night.
Thank you all so much.
Thank
You all have a great night. God bless us, everyone, and you are not alone. Thank you all so much. Good night.
Thank you.
Thank
Thank
you.
you all. Thank you.
Amen.
Much love.
Good night.
Good night. Love y'all.